give everybody a couple of minutes to sign on here. Hello, Darren from the North Slope. We're going to start promptly at 6 o'clock our time and 9 o'clock the speaker's time. So while we're getting everybody to sign on, if we can just get to make sure, a lot of you I've seen before on here, but if you guys can just do the raise hand function on your devices. There you go, I see you, Kate. If everybody else can just, there should be on the right hand side a raise hand function. Thank you, Ron. We will use that to ask questions, or if you wanted to chat with our speaker, we'll use that function where you can raise your hand or ask a question. Thank you, Keith. And then we will be able to get back with you when the speaker has a moment to pause for questions. And we can either open up your mic so you can ask the question, or we can just ask it for you if you don't have the speaker option. Otherwise, everybody will be muted throughout the presentation. And yes, I hope to see, let me see, I think it's 6 o'clock somewhere. So I think we can go ahead and get started. I'm going to just start the recording. And I would like to give Andrea a very hearty Alaska welcome. Thank you for joining us this evening. It's late at her time, so I'm excited that she was able to join us. And she's one of our potential candidates for coming up to our symposium, so please give us some feedback on Andrea. And I will leave the introductions and where she's from and her wonderful resume she's got to her to introduce herself with. And thank you again, Andrea, for having joining us this evening. And it's all yours.
All right, good evening. It's nice to talk to all you guys way out there. As you can see, you guys are a long ways away from where I'm at. You have a much better view. I believe that's Mount Denali by you guys. And if you look in the other corner, I get to see a lot of flat corn everywhere. So if you guys are nice and I get your bank account numbers and I pay you enough, I would love to come out to Anchorage, Alaska in November and see Alaska myself and all the beauty it has to offer. So I would also like to thank you all for letting me do this tonight. I'm very excited. This is the first time I've actually done a webinar, so bear with me. I am sitting in my kitchen talking to my computer screen, so this is a little bit different than what I'm used to. I'm going to show you where I'm at. See if I can do this here. There I am. I just wanted to show you that I actually dressed up for the occasion. So wanted to let you know I'm not in my pajamas, sitting in my kitchen at 9 o'clock at night. So it's nice to see you all out there. And now, so you don't have to stare at my ugly face all night, I will shut this off.
Wow, that's pretty impressive.
Well, you know,
you're dressing up. I'm pretty sure the rest of us did not dress up.
Well, you guys all got dressed for the occasion, so I figured I better as well. So here we go. So tonight, what I would like to talk to you guys about is, if I can get my computer screen to work here. Here we go. Crash test dummies and football players. I've given this presentation in several places across the United States, and it's a very interesting topic because concussions are starting to become widespread as a big concern, especially in the NFL. So I guess before we go there, I should probably introduce myself. I am a paramedic firefighter. I work for Schererville Fire Department. It's in Northwest Indiana. I've been in EMS since 2003. I've worked as an EMT basic for about 3 years. Then I did the EMT intermediate, I-99 is what it was called. Did that for a few years. Then I went got my firefighter certifications and then my paramedic. So I am not a senior person. I'm not the old fogey in the whole EMS system, but I'm also not a little rookie. So I like to say I'm in the happy middle. I still love my job and love treating people on the ambulance. I also love going around speaking at conferences, so I have a great time doing that and meeting a whole bunch of new people. I also teach in the EMS Academy out here. All of our EMS systems are through the hospital, so I work for St. Anthony's hospital system and teach there in the EMS Academy, and right now we're in the middle of paramedic school, so busy with that. That's about all as for me, so onward we go. So, crash test dummies and football players. What we're going to cover tonight is going to be several things. We're going to talk about concussions, also sudden cardiac arrest of the athlete, femur fractures and Le Fort fractures. Two injuries that we don't see often, especially Le Fort fractures, but they're both major injuries that can cause a lot of trauma. Especially out where you guys are at, I know there's a lot of off-roading stuff, ATVs, snow machines. Those can cause a lot of the femur fractures and Le Fort fractures, which I'm sure you guys see probably more of than what we do out here. We're also going to talk about the treatment of it, shocking statistics, and the conclusion. So as we go through, we're going to talk about each of those different injuries, and then at the end, we're actually going to talk about the treatment. So don't get concerned if you hear about the injury and don't hear about the treatment, because it will come at the end. I put it at the end just as sort of a review of what we talked about earlier on. And especially since this is about an hour and a half long, I just want to be able to review at the end. So, the first thing, concussions. This is a very interesting topic. I could probably talk for about 4 hours on just concussions itself. But what is very important is this day and age, there are so many athletes and young kids getting involved in contact sports. And they're finding out that a lot of injuries are happening at the very early age. With the emphasis on sports, you know, all these parents want their kids to go play for the NFL, get those scholarships to college, and they push and push and push them to do sports. So they're finding out a lot of injuries are happening early on that they weren't aware of earlier. So what are concussions? Obviously, they're more serious than just getting your bell rung. That used to be a thing, you know, you'd be in a contact sport, and if you got knocked out, that was almost like a rite of passage for you. But as they're seeing, that is a very bad thing to happen to you. So first off, what is a concussion? A concussion is a brain injury caused by a blow to the head or the body that causes the brain to move violently against the opposite side of the skull. So pretty much your brain is getting sloshed all over the place in your brain. Like I said, you do not have to lose consciousness to have a concussion. So beware of that. If you guys respond to high school sports, to middle school sports, even to any other sporting activity or any calls where someone falls and hits their head, they may not have to lose concussion to have, or consciousness to have a concussion. So keep that in mind, and you'll find out why here shortly. So in order to understand concussions and severity of it, I thought we'd go over the pathophysiology of a concussion. The brain is a very complex thing, and anytime there's an injury to it, it can cause a lot of different things to happen, things that we don't even know that's going on the inside of our brain. So first off, your brain is suspended in the skull by the cerebrospinal fluid, which we've all learned in class. What I didn't know was there's 78% water in your brain. So your brain is actually floating in this fluid. The interesting part is the more dehydrated that you get, the less fluid there is in there. It actually dehydrates your brain, like the fluid in there. So say you have a football player, or you have a soccer player or baseball player, or anybody that's running around and they're sweating and they're getting dehydrated, their brain is already less protected from getting injured. So that is a big concern, because you're running around and you're sweating and then you get nailed on the head. You're already going to be at a higher risk for a concussion or a brain injury than you were before you even started practice. So that's something else to keep in mind when you're responding to these types of injuries. Ask them when the last time was they had something to drink, when the last time was they ate, and how much they've been sweating and rehydrating throughout the practice or the game. So, and also like we said, that for a concussion, the force is so great that the cerebral cortex makes contact with the skull. So basically your brain sloshes around and bangs the front of your skull. Now, as we all learned in school at some point in time, as you can see from the picture, there are many different sections or lobes of our brain. You have your occipital lobe, which is in the back of your head. It's that ridge. If you reach around to the back of your head and you can put your fingers right on that ledge, right by your neck, that's your occipital lobe. The parietal lobe obviously is up on the top, temporal lobe's on the side, and the frontal lobe's obviously on the front. So each of these different lobes actually has a different function. And anytime you injure any part of your brain, it's going to affect something. There's nowhere in your brain that you can't whack and not have an effect. So a quick review of what each of those sections do. Your parietal section is the command center. So it's for all your senses. It also combines all your new learning with past experiences. Your frontal lobe is your problem-solving, planning, and reasoning. This is where your emotions, your personality, your short-term memory all hangs out. So if you land and smack the front of your head, you can easily have issues with short-term memory, which is evident in players if they go out on the field and suddenly they can't remember what their play they were supposed to do, or where they're supposed to stand in the lineup if they're playing football, or what their next thing is to do on the playing field. So that's a big red flag right there for these people. Your temporal, which is the side of your head, deals with how you hear and understand what people say. This is where your long-term memory is also stored. So if someone gets whacked on the side of their head, they might have a difficult time hearing their coach and understanding what their coach wants them to do. So you can see how all these different areas affect an athlete, or even just those of us running around and who fall and get hurt. Your cerebellum contains half your neurons in your brain. This is where all your balance and your coordination happen. So again, say you had a basketball player that fell and hit their head, and they hit the cerebellum area. Now they jump up and they start running around pretending they're fine, but they're running around off kilter. You know, like if you spin yourself around and you get dizzy and now you're walking sideways, they might be doing that. They can't dribble the ball like they were able to do about 5-10 minutes ago. So, you know, that's another red flag that you might see. And then the occipital area. This is where your brain understands and processes what red means. So like red means stop, green means go. This is where your eyes and your brain have to work together. So what your eyes are seeing, your brain has to understand what that means. So again, every area of your brain can have potential injury and potential harm, and can have long-term lasting effects. All right, so what does a jar and a brain have to do with anything? Well, Amazon is a very amazing website. Shockingly, I typed in there brain and I got about 12,000 hits, but I was able to find a brain and I put it in a jar. And I'm going to show you here on my webcam what exactly this is. And it's more fun when I'm actually in person. So if I get the opportunity to get out there, I will definitely bring my brain. It has passed through security at airports, so I do know how to get it to where I need to go. So let me show you this here. Okay. Oh, the backwards things of video cameras. All right, here's my brain. Kind of funky looking, isn't it? When I do this in class, I actually hand the brain around, and throughout the whole presentation, the people can kind of play with it. I just advise them don't open the jar lid because then it's a big mess. But, so, what you see here is the brain. And if you see me slashing it around, okay, like this is exactly what your brain looks like in your skull. So, just running around and jumping and doing the things we do in normal life, you can see how the brain actually still slashes around. Now, add being a football player and you smack your head. Do you see how hard that hits the front and how much it slashes around. So not only is it hitting the front or the back, it's hitting all of it at the same time. Okay? Now, add like a rotational injury. If they get smacked on the side or the top and then they get flipped over and then they hit their head again, now you're getting a back and forth and a side to side and a possibly up and down. So it just kind of illustrates to you how your brain hangs out in your skull. Now, the interesting thing I learned about your brain is nothing in our brain really works as a shock absorber. I'm going to shut this off here so I can see what I'm doing. Your brain's shock absorption is actually just the fluid in there. We don't have nice cushions, springs, anything like that on the front or the top or the side of our heads. It's just that fluid. And as you can see, the fluid doesn't protect it that terrible much. It lets it float where it's supposed to, but it doesn't stop it from moving. If you actually think of a woodpecker, woodpeckers, you know, you see them whacking their head, whacking their beak against a tree constantly, hundreds and hundreds of times a day. You'd think they would be getting a concussion, right? I mean, you do that over and over and over. Well, their tongue actually starts in their beak and it wraps around, it goes down their throat, and then it goes up inside their brain, and it actually wraps around their brain. And that acts as the absorber or the cushioning for their brain as they're whacking their head against the tree, which I thought was pretty cool. I wish sometimes we were a little bit like the woodpeckers with all the crazy stuff we do to our heads and everything like that, but we don't have that. We're not lucky enough to have that. So, but God also created us to be smart and know how to take care of ourselves. So I just thought that was pretty interesting about the woodpecker, and I hope you can see with the brain a little bit how our brain actually functions in our head. So, and like I said, if I was there, I'd let you guys hand it around and shake it and play with it a little bit. So the next slide is actually going to be a video of a short clip on how your brain reacts when you get a concussion. So if technology works for us, that's what you're going to be seeing next. All right, I hope you guys saw that okay. But again, just another visual of how our brain floats in our skull and how it can get damaged so easily. So what actually happens in our brain when we get a concussion or we get an injury to the tissue? There's a lot of things that go on at the cellular level that we don't even think about. You know, we're so used to looking on the outside and seeing if there was a loss of consciousness or if they're dizzy, if they're puking, you know, if they're having coordination issues, short-term memory issues, all of that. Well, all of that actually comes from this cellular level where the chemical imbalance starts. So what happens when your brain slashes against your skull? Well, you have a massive energy crisis that goes on. Suddenly your brain is saying, holy cow, something happened, I need to figure out how to fix this. So your tissues in your brain actually shear. The neurons, the brain cells, they actually get stretched and they tear and they shear against each other. Well, now that you have an opening in those brain cells, you have what's called leaky pipes. So now you have a way for things to go in and things to go out, which aren't supposed to happen, which messes with your chemical balance inside and outside of your cells. So what happens is, in our brain, we have what's called a potassium-calcium pump. Just like in the rest of our body, we have that sodium-potassium pump. we have a potassium-calcium pump in our brain. And this goes into overdrive. So suddenly now, potassium and calcium that are inside and outside the cell are going opposite directions. So now you're going to get calcium where it's not supposed to be. You're going to get potassium where it's not supposed to be. And then your body says, I need to increase the energy that's going on to deal with this, to fix the homeostasis that was there that is no longer there. And so it goes into overdrive and it says, I need to make more glucose, I need more energy to help this. Well, at the same time, your blood flow in your brain decreases because it automatically says, I have shearing, I have leaking, I have bleeding, I need to shut down this blood flow so that that can stop because I don't want it to leak and to increase that blood flow anymore. So it can decrease up to 50%. So now you're losing blood circulation in your brain suddenly by smacking your head into your skull. So now you have energy that needs to get increased. You have blood flow that's decreasing, and you have potassium and calcium going all over the place where they're not supposed to go. Your calcium also increases within hours. An increase in calcium decreases your metabolism. So now you have this whole crazy circle. Your brain needs more metabolism because it needs more ATP, but you have increased calcium, which is shutting down your metabolism. So now your brain is just going all haywire and has no idea what to do. You also get an increase in your potassium, and that can increase loss of consciousness. It can give you that amnesia, and it can give you cognitive dysfunction. So as you can see, it's not merely just getting your bell rung and losing consciousness or saying you're dizzy, but all of this is going on inside your head at the deepest level that you can get to in your brain. So in case all of that was super confusing, we're going to keep it simple, and we're just going to say when the chemistry goes wrong, the electrical signals do not work correctly and can't tell the brain what to do. So there's messages getting thrown at your brain on how to do something. Your brain can't read it correctly, so now you're going to get all sorts of things that are off. You're going to get dizzy, you're going to see lights, you're going to not remember something, you're going to be uncoordinated. Everything that happens in those different lobes of your brain that we talked about is now going to go haywire. So just keep that in mind when you encounter a patient that could have a possible concussion, that not only is it the outside symptoms, but it's all this stuff going on the inside. So here's just a picture a little bit of the cellular level, or the neuron right there. You can see your potassium is going outside and your calcium is coming inside, which you don't want. You want things to stay where they're supposed to be. But that blue circle right there is where, like, say, the tearing is going on, and that just gives an opening now for everything to switch and to go where it's not supposed to go. So I hope that makes a little bit of more sense as well, looking at it that way. If you're one of those chemistry people that, you know, this kind of stuff makes more sense. All right, so now that we have an idea of actually what goes on inside your head when your patient has a concussion, we're going to talk about some of the outside symptoms that you can notice. Now, this also can apply not only to your patients that you might encounter, but I don't know how many of you out there have sons or daughters or sisters and brothers or nieces and nephews, or, you know, friends that have kids that play sports. A lot of this you can also use to monitor those people in your family that play sports. So some of these things that you're going to see as either a parent, a teacher, if you coach. I don't know how many of you out there coach, you know, youth sports, but this is what you're going to see. You're going to see the patient or the player acting confused or forgetful. Remember, we talked about that. Unsure of plays, so that short-term memory. They play clumsily, so you're seeing that loss of coordination. They can't recall events prior or after the hit, so they don't remember what happened. You may also see a change of behavior or a change in their personality. So that's something that you might see in your patient or your athlete that you're coaching or your kids. What the athlete or your patient might report is nausea or vomiting, dizziness, balance problems, sluggish, groggy, headache, that double vision, blurred vision, things like that. Now, we have to remember, which is very important for those of you in the pre-hospital setting, how many of kids these days in sports do you think are going to actually report any of these symptoms? Probably not too many, because they want to play, they want to stay in the game, they don't want to get taken out for a week or two to go through all of the concussion protocol and get signed off by a doctor to go back to play, right? I mean, these kids are pretty die-hard players. You have kids that want to get that scholarship to get to a college, you know, want to get drafted into whatever sport they're in. So they're going to be very, very reluctant to admit that they're having anything going on, because they know the minute they do that, they're going to get yanked out of the game. So keep that in mind. We don't want to be too quick to sign these patients off if we get called for a possible concussion, because they can lie and lie looking at you about, you know, how they're feeling. In reality, they could be looking at two of you or having a headache or, you know, feeling nauseous or something like that, but they're not going to tell you because they don't want to get yanked out of the game. So keep that in mind. Another big issue we have with concussions, especially in the youth, the adolescent era, is what's called second impact syndrome. Now, second impact syndrome happens after you have that first concussion, and it happens when the tissue that got damaged from the first concussion does not have a time to heal. Now, this can come from, like we were just saying, that athlete that does not report any of those symptoms and is able to fake that they are not hurt or they did not get a concussion. So what happens is you get that player that had the first concussion, say, at Friday night's game. They come to practice on Monday, Tuesday, or Wednesday, and they get hit in the head again. And suddenly now that same area that got bruised the first time, that is having the leaky pipe issue, that is having all of this stuff at the cellular level going on, it gets hit again. Now, the bad part about this is there's a very high morbidity and mortality rate seen when this happens. It doesn't have to be that big of a hit as the first one, but the problem is that it's hitting the exact same area that got damaged the first time around. Because of this, you have a 50% chance of death getting hit that second time around. And you have a 100% likely chance to have permanent neurological damage. And it might not be hugely significant right away, but it might show up later as they get older, where they have that personality change, the behavior change, the inability to concentrate when they're at school, that sort of thing. So this is where keeping an eye on those kids, the younger kids running around playing sports, can have a significant impact on the future. So we need to make sure we catch these concussions early, because they can have devastating effects later. I have a story on Dateline I saw about a couple months ago. I gave this presentation in North Dakota in April, and the night before I left, they actually had a special on there, and it was a mother of a high school student, and she said that her son begged and begged and begged her to play football, and she didn't want to because she was a nurse and she knew all of the issues with concussions and injuries and things like that. And he begged her and begged her, and she said, fine, I will let you play. And this exact thing happened to him. He went out there, he got hit in the head, he got a concussion, he went right back out there. because it wasn't caught the first time. He went out there, he got hit, and he died. He ended up dying shortly after getting hit that second time. So it does happen. It is out there. So it's something to be very, very aware of. All right, so what are you going to see for symptoms of secondary impact? Well, within minutes of this impact, you're going to see the patient or the athlete appear to be dazed. They'll collapse, their pupils dilate, their eye movement's lost, and they might actually go into respiratory failure. So these are the patients you're going to get called for unresponsive on the playing field or unresponsive on the gym floor, unresponsive, wherever the sporting event's taking place. So this might be a reason as to why they are the way they are. So keep that in mind. It's a very, very dangerous thing to have happen. Another thing we talk about that can happen from concussions again is what's called mild traumatic brain injury, or MTBI. What it is it's a traumatically induced alteration in brain function caused by repeated blows to the head. So these are those high school players, those football players that are getting out there and constantly getting their head banged over and over and over. Remember what we were saying before, the athlete can possibly ignore it, hide the symptoms, and not report it. So this is usually in the older population, not that pediatric population where they're not going to get that secondary impact syndrome. But this is a big issue as well because it does not allow the brain to heal after that initial injury. So you're just going to be hitting the same spots over and over and over, and nothing's going to heal the way it's supposed to. So what are some of the symptoms you're going to see of this? Well, this is where you're going to see a little bit more of the personality and behavior changes, the cognitive changes. Teachers might actually start seeing this in their students when they're off the playing field. They're going to see changes where they become easily frustrated, they can't follow directions, decreased short-term memory, delayed mental processing. Like I said, the teachers may notice the reduced academics. So they might be a straight A, high B student out there, and suddenly they're hanging out in the C range with their grades because their brain is not functioning the way it used to because of the repeated blows. You might also see excessively tired. So the kids are falling asleep in the classroom. You're going to see these types of people that aren't normally aggressive in the classroom or even on the playing field, and now suddenly they're having issues with aggression and they're starting to take it out on students and athletes and players like that. And that's all coming from repeated blows to the head, all these concussions. So I hope you're seeing as we're going through this how bad concussions can be and how important it is to catch a concussion the very first time around if you can, because all it is just it's a domino effect on this person's brain and everything that can happen if you don't catch it right away. Okay, chronic traumatic encephalopathy. This is another huge thing that is happening. This whole discovery of this came from Dr. Amalu. I don't know if any of you heard of the movie Concussion. It came out a couple of years ago with Will Smith in it. And I actually made a lot of my presentation for another conference I did, and this movie came out, and I thought it was really cool because as I was watching the movie, I was seeing that a lot of the stuff that I had in my presentation was in the movie, which was awesome to see. But if you have a chance and you're interested in this whole concussion thing and sports injuries, definitely get this movie. It's very good. There's not action, there's no blood, there's no shoot 'em up, bang 'em up, that kind of thing. But it's a very interesting, informative movie. But what happened was this Dr. Amalu worked in Pittsburgh, and he did all of the autopsies for the county, and very, very smart guy. Well, he happened to get the autopsy of a ex-NFL player called Mike Webster, which is the picture of him in the bottom corner there. Mike Webster was a huge Pittsburgh Steelers player. Pittsburgh loves their Steelers, their NFL team, and he ended up committing suicide. He killed himself in a truck. He was homeless, living in his pickup truck in like a junkyard. He used to be married. He was divorced. He had all these issues going on, and they found him dead in his truck. Dr. Malu ended up getting the autopsy. And as he's working on this guy, he just cannot figure out how this young 50-year-old guy could have all of these problems suddenly and end up killing himself. Because when he did the autopsy, there was absolutely nothing wrong with him in his body. Everything was looking pretty good. And he was getting pressured by the city of Pittsburgh to just close the case, say it was a suicide, and not dig into it too deeply because they didn't want to ruin this guy's reputation. Well, Dr. Amalu said there is something wrong. There is something that caused this to happen. And so he spent his own money and did this brain research, and he took all of these tissue samples out of Mike Webster's brain, and he discovered that there was an increase of tau protein. Now, this tau protein is usually found in Alzheimer's patients, and you can't get Alzheimer's being young. You just can't. It's impossible. So they were saying that he had like Alzheimer's, and he said, no, you can't do that. That doesn't happen. There's a reason why there's this increase of this protein in this player's head. So he ended up looking at 4 NFL players and 1 boxer, and the 4 NFL players that he looked at committed suicide previously. So he was able to get their brains so he could do tissue samples on it. And he found the exact same thing in every single brain. And so he went on to write a journal paper, which I was actually lucky enough to find. I have the journal paper at home actually, and it's pretty impressive reading it. But he found out that this tau protein comes from repetitive hits to the head. So he found the link between head trauma and long-term brain disease, also known as CTE, and that this was actually causing all these players to commit suicide and to have major issues after they got done playing. And as it says up there, it usually occurred about 12 years after playing. And this movie shows several of the players that had committed suicide and how they were behaving now compared to before. So very, very interesting movie. And it's awesome that this Dr. Malo figured this out. The problem is the NFL went after him and said, you can't shut us down. We own Sunday. And so they put a lot of pressure on him, and thankfully he was confident enough with his findings and was able to get this out to the world. So that's now why you have some of these new rules for concussions in the NFL. So some of the signs and symptoms you're going to find from the CTE is the loss of memory, loss of functioning, and the big stuff here is your the paranoid ideations, your anger, violence, rapid fluctuations of moods, major depression, headaches, criminal violent behavior, alcohol, drug abuse, dementia, Parkinsonism, that kind of stuff that is all going on in all these relatively healthy people. Now, if you look at that picture, you'll see at the bottom there the normal brain on the left. Okay, that's your and my brains, what it would look like if he was able to look at ours for the most part. Mine might not be that normal, but that's what it looks like. Now, if you look at the one on the right, guess whose brain that actually is? It's Mike Webster's brain. So you can see the complete difference of what a normal brain looks like compared to NFL players' brains. So I thought that was very, very interesting to see. And on a side note, I actually had dinner with an ex-Pittsburgh Steeler NFL player. He won 2 NFL Super Bowls, and he lives in our town, Ted Peterson. And my husband and I went to a dinner with him, and I told him I was doing all of this research and stuff, and he kind of looked at me and he said, so do I have these symptoms? Am I going to end up this way? And I said, I think you're fine, but he actually played with Mike Webster, so I thought that was pretty interesting to be able to talk to someone who played with him, and he was able to tell me a lot about Mike Webster and how sad the outcome was for him. So again, right there is just a real picture, you know, an illustration of what these brains are looking like that are getting these repeated concussions over and over and over. All right, so here's all of you guys' homework to do. Now, this is something that I do when I'm actually standing in front of you all and giving the presentation, but what I want you to do is when you go home, take a jar, like a regular mason jar, and fill it about halfway with water, and then put a raw egg in there. And then obviously put a lid on it so you don't get yourself all wet. And take that jar with that egg, tip it sideways like I was doing with the jar, the brain in the jar. And I want you to shake that egg back and forth. Not too hard, but just enough so you can get the egg to hit the front or the back of the jar. And the key is not to fill the jar all the way up with water. You have to do it halfway so you have room for the egg to kind of slosh around in there. And I want you just to hit it a little harder and then a little harder each time, and look at that egg and see how hard of a hit it took to actually just crack the egg. And it doesn't take a whole lot. I was trying to look up the actual force of cracking an egg, and the best I could come up with was it took about 20 G's, or that gravitational force, to crack an egg. So do that and pay attention to all of the little cracks in that eggshell as you're slashing it around. This picture shows about 4 in there, but just put 1 in there. And then just keep shaking it over and over until the egg actually breaks. And what it does is it just gives you a really good hands-on demonstration of our brain and how fragile it is, and how you can keep cracking it and cracking it and cracking it. And slowly you're going to get that fluid leaking out, like we talked about the leaky pipes. You'll see the yolk starting to come out, and then eventually the egg will crack all the way. So it's kind of a fun thing to do. But go home and do that. And I'd say let me know how it goes, but I'm really far away. So just have fun with that. And if I see you guys in person, I will definitely be bringing my egg in a jar with me. Okay, so now that we've learned all about concussions, head injuries, that sort of thing, what does it actually have in common with football players? Hence the title of the presentation. Well, football and crash test dummies, they actually have a lot in common. And they actually relate to concussions, and we're going to see why. So what they have in common is what's called the G-force, or the measure of the acceleration against the Earth's gravitational pull. So your G-force. Now we've all felt it if we've flown in airplanes and we've landed and we've taken off, if we've been driving in a car and gone too fast, if we're driving that four-wheeler and hit the brakes too fast and go flying over the handlebars, that kind of stuff, you'll feel that gravitational force. So we've all been there. So just so you get an idea of G-force comparisons in the real world, a fighter jet or a roller coaster only has about 4.5 Gs. So a little bit more force than what we feel when we're in an airplane, but those of us, or those of you that have been on a roller coaster, you'll feel it, especially on the downhill part of the hill. Car crash dummies, on the other hand, they slam into the windshield at 100 Gs. And that's how hard it takes to break a windshield. So keep that in mind. Keep that 100 Gs in your head as we continue. So, like I said, there's been quite a significance in the research done for concussions. And what they're trying to do is trying to figure out the G-force impact on people's brains when they're getting hit. So what they did is they came up with this head impact telemetry system, or HITS as it's known as. Now if you look at the helmet on the left side, you're going to see all those round little circles inside the helmet. And then on the other helmet you'll see the triangles on the back of the helmet. These are all sensors. And what they've done is they've had certain football teams that they followed, usually college teams, some high school teams. They'll have the athletes wear these helmets, and they'll measure all of the impact that they get over a period of time or over a season of games. And as you can see in the right side there, it has all those different arrows pointing at the head. Well, this was the results of those sensors in that helmet. The longer the arrow, the longer the impact, or the harder the impact that was had on the head. So as you can see, there's quite a bit of longer arrows on the top and the front of the head. Now, excuse me, the University of North Carolina, did a study of 60 football players. They really wanted to see how many times that a football player actually gets hit on the head. And what they found out was an average football player in high school gets hit 1,000 times. So they put these telemetry systems on high school players and college players and measured all of this stuff. So 1,000 times, that's quite a bit. They found out that total helmet hits were 104,000 times in a year or a season of football. That is a ridiculous amount of times that a person gets hit on the head. I mean, that's just absolutely crazy. That number floored me. What they also found was the average G-force of hits to the top of the head were 29 Gs. Now, obviously, to the top of the head, that takes quite a bit of force to make that happen. So, and the right lineup of direction of the head. So the force on the top of the head is not going to be as significant as it will be on the side or the back of the helmet. So the top of the head was 29. The normal G-force range was 50 to 100, but there was several that was over 200 Gs. Now, how many Gs does it take a crash test tell me to break the windshield? That was about 100. So now you have these kids running around getting hit at over 200 Gs on certain impacts. And they just get up and they keep going. How many concussions do you think are actually happening that players aren't reporting or hiding the symptoms because they keep wanting to play? 200 Gs is an amazing, amazing amount of force to get hit. So again, this is why we have to be so aware of calls that we go on that have to deal with concussions, because they are getting hit well over the force that it takes a crash test dummy to hit a windshield. Now, they continued the study, and what people thought was that hits to the top of the head were about 5 to 6% when they had to guess and they had to average. What they found out was it was actually greater than 19%. So that's quite a bit more. 6 of 13 concussions came from top of the head hits. Again, that would be more than I would think would happen. The NFL originally stated that hits of 85 Gs or more are only what caused concussions. What they found out was actually most concussions are caused from 60 and under than 85 and greater. So if you think about that, how many concussions, again, did the NFL miss when they thought only 85 Gs or more caused concussions? They weren't concerned with anything under 60. So that's why you're getting these Mike Websters later on that are having all of these issues, because all of these times they got hit on the head at under 85, they weren't too concerned with it. Players with impacts of 60 Gs or lower actually tested worse than those over 85 Gs. So the other interesting thing I've learned is the NFL's expert team that came up with these concussion rules earlier on actually had podiatrists in there. They had other doctors that have nothing to do with head injuries or neurology or anything like that. I think there was like a chiropractor in there, a podiatrist, so that was pretty funny to me that they had those people on their expert panel. So what also did these helmet telemetry systems find? Well, they found out that offensive and defensive linemen experience the most hits. Now, I don't know a ton about football. I like watching the NFL, but I am not an expert in all of the different positions. So those of you that coach football and know a little bit of it might understand this a little bit more than those of us that don't play football. But offensive back, defensive back, linebackers, and wide receivers receive less hits. Offensive backs have 80 Gs of impact, and running backs and receivers receive harder but less impact. So they're getting hit harder but not as much. So you got to keep an eye on those too. So if you know what position, like say even your child plays or you're coaching, or if you get this call for a concussion, find out what position they play too, and that might give you an idea of how many times they've possibly been hit that night or how hard. So that is just a little bit of info there for all you football people out there. All right, so excuse me, I got this cold I cannot shake. Testing for concussions. How is this done out in the real world? Well, what they have for these athlete players is what's called a SCAT test. There's several different ones. The SCAT test is the Sport Concussion Assessment Tool. This is basically a standardized method of evaluating these players after a concussion. It's 2 pages of different evaluations they have to get, and it's a paper and pencil test, which works out fine if you don't have the ability to use a computer-based test or something like that. But the problem with this kind of an assessment tool is it leaves a lot of room for error, especially for those students, like we said earlier, those athletes who don't want to get pulled from the game. So basically this is what it looks like, the SCAT-2 test. On the right-hand side, under symptom evaluation, you basically just ask them, like, do you have a headache? Is there none? Is it mild, moderate, or severe? And you go through this whole list of headaches, nausea, dizziness, blurred vision, sensitivity to noise, all the way down to irritability, drowsiness, confusion, sadness. I guess, you know, they might be crying because they are taken out of the game, or nervous or anxious, that sort of thing. So again, how easy is it for these athletes to lie about how they are feeling if all they have to do is answer none to severe? Pretty easy, I would imagine. So they came up with this other test called an impact test, the immediate post-concussion assessment and cognitive testing. Ooh, spelling mistake there. Sorry about that. It's one of the most widely used computerized tests out there to evaluate concussions. Now, this thing works awesome because first what you do is stage 1 is done when you start the school year. If you're new to the sport, like say you're a new student that moved into the area, if you're just starting the sport for the first time or something like that, you get online and you do a 25-minute test. And what it does is it measures your attention span, your working memory, problem solving, reaction time, that sort of thing. So it asks you all different things like list these numbers and read this sentence, read this paragraph. You know, they'll give you a list of like 5 different words and then have you repeat what those words were like 5 seconds later, that sort of thing. And it records in that whole testing 22 different concussion symptoms are written into this test. And so like I said, you take it every 2 years at the start of your season or, you know, if you've had a concussion event. But the cool thing is you do this and then your coach or the athletic trainer or whoever is on the sidelines who gets the job of monitoring all this can take these this data and how you scored on it and take it right to the field. So then when, say you suspect a player has had a concussion, you yank that player out and you actually give them this test right there, right then when they get yanked. So they have no time to think about their answers. They have no time to figure out how they're going to lie their way through this. And they retake the test that they just took at the beginning of the season or every 2 years or whenever they did it. And based on their results from that, they compare it to the score from the first stage when they first took it compared to the post-injury test. And if there is any sort of difference in their scoring, it will tell them immediately that they have a concussion. So this test is actually really cool because these athletes can't fake or lie their way through this test. So a coach or athletic director or even you as EMS providers, you can come up on scene to this event and you can ask whoever's on the scene, hey, did you do a impact test? Did you do a scat? Did you do any sort of post-concussion test? And if you did, what was their score? So this again is a really good way to start catching these concussions as they happen. So why are concussions so important to EMS? Well, I hope by now you're starting to see how important it is. Concussion symptoms can be easily missed. As I said before, these athletes can lie their way through anything. If any of us know teenagers, we know they can lie about a lot of stuff. And they can, you know, try to finagle their way through so that they don't get yanked out of a game. So they're very easy to miss by us just asking questions. So we have to learn the right questions to ask, what to look for, and how to evaluate a concussion, which we'll go through later on. As we stressed again earlier, a missed possible concussion can have devastating effects later with that secondary impact syndrome, your CTE, or mild traumatic brain injury. All of that, by missing one concussion, can have major impacts in the future for these athletes. So it's very, very important to be able to catch a head injury right off the get-go. Like we said, players may not be telling the whole truth, okay? So really, really evaluate these students. Find out what your protocol is where you work, the protocol for the high school or the middle school or wherever you are responding to. Find out what their rules are for taking a patient out of a game, taking an athlete out of the game, if you're allowed to sign them off, or if they automatically have to get transported to get evaluated, that sort of thing. So go talk to your schools, go talk to your athletic events, the Little League, the different things like that. If you have the junior, like football, Pop Warner type of things for football for the little guys. I mean, these kids are so little, their helmets are bigger and way more than they do. So catching this stuff early on can really, really save these kids from especially the secondary impact syndrome. And football players, like I said, they're essentially crash test dummies running around in the field. So do not get that refusal, okay? Imagine every single football player is a crash test dummy, and when they get hit and they get injured, they're getting hit harder than the crash test dummy getting thrown into a windshield. And all of us who have been on nasty, bad 1050s car accidents, we see what a head does to a windshield. And that's what happens to these kids running around on a field. They're getting smacked that hard, if not more. And then they're getting up and they're running around and doing it all over again. So I hope through all of this that you are seeing the importance of catching these concussions early on. So that's it for the concussion thing. Now we're going to move on to another big issue with athletes and sports injuries, the sudden cardiac arrest. We all hate when we get that call for unresponsive and not breathing. on the field, right? I mean, that's not a good call for us, because a lot of us that work in small towns, that work in areas where we know everybody, the chances of us knowing somebody on this call is pretty high. So especially kid calls, we all hate kid calls. I hate kid calls. The pediatric calls, you add, you know, a small town on top of a kid, this stuff can be pretty devastating to even us as EMS providers. So we're just going to go through a couple reasons as to why this can happen and what you guys can look for when you respond to the scene. So what is sudden cardiac arrest? Obviously, it's the sudden, unexpected loss of heart function, right? If you know the rhythm on the bottom, you're going to see that that's VFib. So ventricular fibrillation, you get that lethal electrical rhythm disturbance that stops your blood flow, stops everything in your heart. So as the term is, sudden cardiac arrest, it's the sudden arrest of your heart pumping. And that's what happens to these athletes. They're running around and they're just fine, and then all of a sudden they're down for the count and they're not breathing. So what are you going to get as symptoms of sudden cardiac arrest? Sometimes you might get the shortness of breath, you might get the chest pain, you might get the syncope or the passing out, but most of the time you're not going to see any symptoms at all. Usually the chest pain, that sort of thing, might actually be reported by the athlete, like say to their parents. They might be having a little bit of like palpitations. They might feel more short of breath when they're practicing out on the field, and that's not normal. Again, how open are our teenagers and our athletes to talking to us, especially parents? You know, are they going to actually tell you that they're not feeling that good? So you may not know anything at all that's going on. So there's two causes for sudden cardiac arrest in these athletes. The first one is hypertrophic cardiomyopathy. So great big word for a great big heart. This is a gene mutation that these kids are usually born with. The heart tissue becomes large and it doesn't allow for the heart to pump blood like it normally does. There's blood flow blockage, mitral valve problems, and then sudden death. Usually this is found at an autopsy, unfortunately, and they'll find out that they had an enlarged heart. A lot of these athletes that are dying have this, and then they find out that it's actually in the family. So they were born with it, they had it, they don't know they had it, and now suddenly their heart stops while they're playing. So here's a picture of what a normal heart looks like and then what an enlarged heart looks like. So as you can see on the left side, the left ventricle is nice and open and big, right? The right ventricle is open. You get a lot of that preload coming in there. You get a lot of the blood flowing into that right ventricle. And then you get just as much return out of the lungs back into the left ventricle and then pumped out through the aorta, right? If we remember the whole circulation of the heart, that's how that goes. Now, if you look at the right side picture with the enlarged heart, look at the difference between the left ventricle of a normal heart and the left ventricle of an enlarged heart. And then look at the aortic valve. There is so much difference in there. So if you imagine all of the blood coming in to that left side, where is it going to go? I mean, you don't have a whole lot of area for that blood to collect. So you have athletes that are running around that are already maximizing their cardiac output, and they're breathing and their heart pumping and their pulse rate's up, and now you add an enlarged heart where they're not even getting that much blood back into their system. So it's just a recipe for disaster. So this is what they're finding on these students that die suddenly. They have this enlarged heart, and this is what happens. Their heart just gives out. It can't pump anymore. So signs and symptoms. What are you gonna see? Again, very few. That's what's so sad about this, is a lot of times there's just absolutely no warning. Again, the shortness of breath, the chest pain. They have the palpitations. You might see an arrhythmia on an echo if you get that done. You might have a heart murmur if the doctor's listening to the heart. But again, a lot of this is not seen, and it's not getting caught because it's so sudden and it happens so quickly. I wish that there could be a rule that every athlete that goes out there gets a cardiac workup done, gets an echo done, gets their heart checked out. Now, granted, that is not real possible with insurance and everybody at different levels with that financial-wise, but I think we could catch a lot of these student deaths, athlete deaths, by getting that clinical evaluation done even before they start playing. So if the world was perfect and I could do that, and I would love to do that for everybody. All right, so the first one was the enlarged heart. The second one is called commotio cordis. Now, this is ventricular fibrillation and sudden death that is triggered by a blow to the chest or right to the sternum. This is something that has absolutely nothing to do with the anatomy or the physiology or anything of the athlete. This has everything to do with perfect timing. Being in the wrong place at the wrong time is what causes this. And what happens is these athletes get hit in the chest right when that T wave, right before the T wave peaks. And you'll see it in this picture here. So if you look at the rhythm, you have your P wave, your QRS, and then your T wave. So those who have gone through cardiology, if you're like me, you remember sweating through trying to learn all this stuff. So basically, if you look at that red vertical line, that is where the athlete gets hit in the chest, whether it be by a ball, an elbow, a foot, a helmet to the chest, something like that. And it's right before that repolarization. So right before the ventricles are filling up to pump out that blood, they get hit right there, and it causes immediate ventricular fibrillation and sudden death. Now, the good thing about this is if you have excellent training on the use of an AED by your athletic trainers, your coaches, parents, anything like that, if you can get the AED on this athlete quickly, the chances of getting them back are very good because it's basically just an electrical issue, okay? You have the ventricular fibrillation. We know if we shock them, we can basically restart the heart, and that's what needs to be done. This heart just got thrown out of whack, and now it needs to get shocked back to normal. So getting that AED out there on the field, getting that training to where you work, the athletic places, the schools, sporting events, all of that is very important for being able to save this athlete's life. So again, get out there in your community and get that training out there for these people to be able to throw an AED on someone and save them. So again, there are no signs and symptoms because there's absolutely nothing wrong with this patient prior to the event. So there's nothing to predict. It's just a sudden cardiac arrest. After the fact, you're going to see the bruises. So if you get called for unresponsive on the field, rip open their uniform, cut it off, look and see if you see any bruising on that chest. That's going to be pretty indicative of what caused this sudden cardiac arrest in your patient. All right. Yucky. No warning for that picture, huh? Whew. We went from that to that. So now that we've covered head injuries and we've covered sudden cardiac arrest, the last 20 minutes or so, I want to go over two other injuries that we see not so frequently, depending on where we work. Up by you guys, I know there's a lot of snowmobiling and skiing, ATVs, off-roading, that sort of thing. Out by us, we do a lot of snowmobiling. We have some skiing. We're pretty flat out here. But we have a lot of lakes and a lot of wave running and boating and things like that go on. So that's where you're going to see some of these other sporting type injuries. So we're going to talk about fractures, the big and the ugly. So we're going to talk about femur fractures and Lefort fractures. Lefort fractures we don't see very often. Femur fractures we might see a little bit more frequency of them, but always a very good thing to review. So I hope you all ate dinner before you came. Otherwise, if not, you might not want some after seeing that picture, unless you're in the mood for a steak or something. All right, so femur fractures. Obviously, if you remember that song, thigh bone's connected to the hip bone. We all know where the femur is in your body. It's the big bone between your hip and your knee. Fracture is a break, so you get a femur and you get a fracture. You get a major possibility for trauma and death, because what is going to happen when we get a femur fracture? We remember back in school, you get a lot of bleeding, right? You can get blood pooling in your pelvis. You can bleed out from that spot very, very easily. So there's a few types of femur fractures. The first one is called transverse. This is actually a break in a straight line. This actually is an x-ray of someone that broke both femurs. I have no idea what they were doing. Might have, come up and hit the handlebars of something like an ATV, snowmobile, wave runner, something like that, but with enough significant impact that it breaks it right in that horizontal line. The second one is called comminuted. Now, if you look at this picture, you're going to see that there are a lot of pieces to that femur. So this is where the bone breaks into 3 or more pieces. Now, if you think about it, the more force there is, the more pieces that are going to break. So if you see this type of fracture, you're most likely going to feel it. It's going to be crepitous. Really look at the impact of what hit that femur when you get called on scene, and look at the mechanism of injury, and that might give you a clue as to how badly this person has been injured, and also what other injuries to look for, because if you have that big of a break in your femur, you might have some issues with your hip, your spine, that sort of thing. So if you look at that, it's all broken into pieces, and then there's an x-ray of how they actually fixed it with the rod and the pins in there. And then, like our first picture, we have open. So this is when the bone breaks out and sticks out of the skin. These are really nasty for us to see. They're gross. Again, significant amount of force is needed to break that. This has a big risk for infections, though. As you see, now you're out in the open air. It can get debris on it. It can get dirt. You can get infections that way. So the big thing to remember is to try to keep this as clean as you can while you're working on it. So what are we going to look for femur fractures? Well, you're going to look for that shortened leg, right? Externally rotated. You're going to have swelling in the mid-thigh, and generally that comes from the hemorrhaging, so the bleeding that's pooling in there. So a high suspect for shock, hypovolemic shock, if you have this kind of an injury, especially if you get a lot of swelling in there. There's an awful lot of blood that's getting lost in there. They're going to have severe pain, and they're going to have a significant amount of bruising. So anytime you have this possible kind of injury, this is where we really stress, you make them naked, you cut off their clothes so you can actually see everywhere that they possibly could have gotten hurt. So really expose the areas, make sure you're seeing everything that you can see so that you don't miss this, because they can easily bleed out and go into shock, and you might not even know it because you didn't cut off their jeans, or you didn't cut off their snow pants or anything like that, and know what's going on in there. So high index of suspicion when you have this kind of an injury. All right, so we talked about femur fractures. Now we're going to talk about Le Fort fractures. Now this has a big impact on our airway, right? Airway. Le Fort fractures are awful. They don't happen a whole lot, so we don't get a lot of experience in managing an airway of this type of a patient, but it's out there. It does happen. So I thought it'd be a good review of going over these kind of fractures. And those of you that are advanced life support, or as I looked up your levels of certification out in Alaska, and it looks like you have the level there's 1, 2, 3, then you have the trauma one above the one, and then I believe you have the mobile intensive care paramedic. So for those of you that are further down in the like the EMT3 and the paramedic, where you're going to do more of the advanced airway skills, keep this in mind as we're reviewing this, and think about how you would secure an airway on this patient if you're an advanced life support provider. So Lefort fractures. Well, there's 3 of them. They're fractures involving the mid-face region, right? So right around the nose and the jaw and the mandible. This was discovered by Dr. René Lefort. He kind of created these 3 different types of fractures. There's a picture of him there. He did this in 1901. I think it's kind of funny because he kind of looks like those skulls on that picture. So I don't know, kind of a weird looking dude, but he came up with all of these. So as you can see, there's Lefort 1, 2, and 3. Now, I'm a visual person, so I'm going to show you how I remember all of these. So Lefort 1 is fractures involving the maxilla, okay, up to the nasal fossa. So if you think of 1, you think of 1 fracture. So what do we have right below the nose? We have 1 fracture, right? So the number 1. So Lefort 1 is 1 fracture, the number 1. So hopefully you can remember that. The second one are fractures involving the nasal bones and then up into the orbit. So this is shaped more like a pyramid. So as you see now, we have 2 lines, right? So Lefort 2 is going to be 2 lines. So this is how we remember this. 2 lines, Lefort 2. So it goes up and it makes that pyramid right over your nose, the bones of your nose. So now we're getting a more significant injury to the face. If you think about it, now your airway has potential to being compromised with this kind of a fracture. So Lefort 1 had the 1 fracture. Lefort 2 has the 2 fractures. Now it is like 10:15 out here, so if you're actually awake out there, you should be able to catch on to what Lefort 3 is going to be. So these are fractures that actually dislocate the face, and it involves all the bones of the face. So if you're all awake out there, Lefort 3 is going to have how many fractures? 3. So if you look at this, it's actually like a number 3 turned sideways. So you have the jig-jagged fractures. You got the down into the orbit 1, up over the nose is 2, and then up into the other orbit and down over by the mandible is 3. So you have 3 fractures. So the number 3, Lefort 3, a sideways turn 3. So that's how I remember that. Now this is the worst one to have because this actually dislocates your face. So you can actually take the palm of your hand on these patients' face, put it right over their nose and their cheekbones and pick their face up off their face. It like floats around and it is very, very funky. So what are your signs and symptoms of this? Well, you're obviously going to have your swelling in the midfacial area, the unstable maxilla, right? So the maxilla is the top of your jaw, and then your teeth. Your face is going to appear longer. So if you look at this guy, his nose actually looks a bit longer than what it should be. And look at all of that bruising he's got going on, even into his orbit area, all along the middle of his face. They're going to have nosebleeds, obviously, because you just fractured that whole area. Their teeth are going to be numb and nasal flattening. Now, like I was saying, these types of fractures can cause very severe airway problems and have a major high risk of compromising your airway. So as we've all learned, you're not going to stick a nasal airway into this type of thing, are you? I hope you all say no. You're not. You do not want to intubate or ventilate a brain because they fractured their entire face. So this is where we're going to start thinking about more of our advanced airways, so our emergency tracheotomy, that sort of thing. So make sure when you go back to your ambulances and you're able to do a cricothyrotomy that you know where your equipment is in case you ever need to do this. So, like I said, we talked about all of our different types of sports injuries, from concussions to sudden cardiac arrest. We talked about the two causes of sudden cardiac arrest. We talked about femur fractures and Le Fort fractures. So now we're going to review what to do for each of these patients. So that's going to be our review of everything we just talked about. All right, so for concussions, early recognition. I hope you have figured out my emphasis on this, of early recognition of concussions, okay, is a very, very, very important thing. Obviously, we're going to do our airway, breathing, circulation like we do with everybody. Really look at that neck and spine if they have any pain going on in there, because if they got their head hit hard enough to get a concussion, they're most likely going to have some neck and spinal injuries as well. Remove that face mask to expose the airway. If the helmet comes off, so do the shoulder pads. A lot of ERs that I've talked to don't have a clue what to do with football players and all their gear and all their padding and their helmet and all that stuff. They quite often don't have the right tools available to take like the face mask off and keep the helmet on. They just aren't well educated in that. So if you guys respond to a lot of athletic events, talk to those athletic trainers, train with them, go through their protocols, see what they want you to do as well, and what you want them to do before you even get there. If it's using their tools to take the face mask off, so that's done before you get there, practice with them, train with them, really get down their protocols so that when you do get called to this type of event, you'll have a really good idea of what you're coming to and what's already been done. Practice, there's specific moves that are coming out for moving these injured football players. A new one is what's called the 6-person move. You actually have all these people lift the patient straight up and you slide the board under. So now you're alleviating the whole rotation of when we do log rolling and stuff like that. The college in my area, they're just training all of the fire departments. They're having them all come in and practice with their trainers on how to do this exactly when they get a call at the university for football injuries. So again, talk to your local schools or wherever you are at and really see what they want you to do and really work with them to make this like a united effort to treat these patients. So assessments of a concussion. What can you guys do when you get on scene and to check to see if they have any sort of concussion symptoms going on? Well, you're going to palpate the head and the neck and the facial bones, okay? Make sure that there's no tenderness, swelling, that sort of thing. If there is, have a high suspicion for a concussion. Inspect the nose for deformity or tenderness, okay? Again, like we talked about, look for that Le Fort fracture. That might also be a possibility. You know, they get a concussion because they hit their head so hard and now they have a Le Fort fracture. Look for that cerebrospinal fluid leaking from the ears. That's going to indicate a skull fracture, right? So high suspicion of a concussion if they actually fracture their skull. Make sure you assess the upper and the lower extremities for strength and sensation. Kind of like our stroke test. Have them squeeze your hands, push their feet against your hands. Check their strength. They might actually be pretty weak. You know, a senior high school football player should pretty well be able to squeeze your fingers in half and break them if he was completely strong and with it. And if he's gripping you like a 90-year-old, you know there's definitely something wrong going on there. Check their vision. You know, have them follow your finger. See how well they can move their eyes to follow your finger. Also a big one is the coordination test, okay? Bring their finger to their nose, that sort of thing. You can't fake a coordination test that easily. So that's a really good one for these athletes who you might suspect are not being completely truthful on their symptoms. Do some coordination tests with them and see how well they do. You can have them balance on a foot, stand on their tippy toes and push them from front to back, you know, if they're able to stand up, see how well they can keep their balance, that sort of thing. So kind of push them a little bit with their coordination and see how well they do. Sudden cardiac arrest, obviously, you got to take a deep breath, right? Sudden cardiac arrest, especially for student athletes, it can be a pretty scary thing. So those of us as EMS providers, we really need to take that deep breath, think about what we're doing, follow our protocols. We all have them for cardiac arrest. Again, keep your airway, breathing, circulation in order as we've always done. And early defibrillation for these patients will create the best outcome. So like I was saying earlier, educate, educate, educate. Get out there, talk to your schools, talk to your sporting events, to your venues, everywhere you go, about getting an AED on scene, especially when you're out more in the remote areas where you're not going to have EMS at your door within 5 minutes. You know, around here we're pretty lucky. We can be somewhere within 5 to 10 minutes, but out in the more rural areas, I used to work out in Indiana, and it'd take us 25 minutes to a half hour to get to where we were going. Well, by the time we get called for that sort of a thing, and it's a half hour before we get there, you know, this patient could have been defibrillated a million times before we got there, and their chance of survival could be a lot greater than waiting for us to get there. So educate all your local areas where you go and get those AEDs out there and get them in the hands of the athletic trainers and the coaches for sure. As far as fractures go, the femur fractures, right? We have the traction splint. Make sure you assess for shock. There can be significant blood loss, especially if you see a closed femur fracture, but there's significant swelling going on in there. That's going to be a red flag for a lot of blood loss going on in there. Immobilize the fracture with the traction splint. Review your protocols for traction splints. You know, we're not going to do them with the open femur fracture. Obviously, you don't want to take that bone that's been exposed to the air and the dirt and everything yucky and pop it back inside their body. So, or if you suspect a possible hip injury, knee dislocation, all of that, you make sure you review all your protocols for that. When to use it and when not to. And then the LaForte fractures. Obviously, airway, airway, airway. Here's a picture of someone that had a LaForte fracture and had it all screwed into place again. We had a call where I was working, we responded to the Coast Guard on Lake Michigan. So anytime they had any calls out on Lake Michigan, we would respond with them. And we got a call for a guy on a wave runner, and he was jumping the waves behind his buddy's boat. And he jumped a wave, lost control, flew about 10 feet up in the air, right above his wave runner, and miraculously he came back down on the wave runner, but he hit his face first on the handlebars, obviously causing significant facial damage. And when we got him, the only way that he could breathe was leaning forward. He had so much bleeding happening inside his nose and his face that he was suffocating on the blood. So we had to obviously worry about spinal injuries and spinal fractures, because if you're having that significant of an impact on your face, it could very well cause cervical spine injuries. So they put a seat collar on him, but had him lean forward because, you know, obviously a person needs to breathe. So he was in the position of comfort for breathing. They ended up, before they flew him to the trauma center, they ended up putting drains in his nose so that it would just drain the blood out so he could keep breathing. But for those of us in ALS who do more advanced airways, review your surgical airway procedures, okay? Get the trach kits out, practice them on the dummies. Make sure you know where they're at when you need to use them. This is one of those injuries you're not going to probably get that often, but when you do, you're going to really need to know what to do right away. Again, spinal precautions, be very, very aware of them. And the other big thing too for any of these traumas is be aware of your trauma protocol. Where are you going to go? Where are you going to bring your patient? I was looking at your area out there, and it looks like you have a couple of trauma 2 hospitals and a trauma 4 hospital, so that's pretty good. Review where you can go with your head injury patients, where you go for your more musculoskeletal injuries, that sort of thing. If there's specific hospitals that specialize in more neurology, that sort of thing, be aware of where you can bring your patient to have the best outcome. So keep that in mind. All right, so now that we've learned all about this stuff, let's look at some numbers that are pretty scary. Over 40 million children and adolescents are in sports. In 2015 to 16 alone, there was over 7 million high school athletes, okay? That's an awful lot of athletes that are out there running around with potential concussions. Over 1 million play football. In 2010, there was 50 fatal sports injuries of children in a year. Out by me, there was 7 so far last year. So that's pretty crazy. What I found even more disturbing was there's less than 20% of the 2 to 4 million athlete coaches, young athlete coaches out there that have any sort of training in injury prevention, concussion awareness, and first aid, let alone AED, CPR. So community training, community outreach is huge if you're able to do that. Get the information out there. Thankfully now with the concussion awareness, there is starting to be more protocol, more awareness, more testing that's required of these coaches, but we still have a very long way to go. And then at the bottom there, 3.8 million concussions occur each year. So that's an awful lot. And that's just the reported ones. That's the ones that aren't lying about how they're feeling out there on the field. Like I just said, 50 to 75% of concussions may go unreported. Again, scary, scary number when we're thinking about that secondary impact, right? With those little guys, you know, they might not even know they're having a concussion because they don't know what it feels like. They're afraid to tell mom. They're afraid to tell the coach how they're feeling because they might have thought they did something wrong, you know. I did the wrong play. I moved the wrong way. Now I got hurt. I don't want to tell anybody because I'm scared I'm going to get hollered at. You know, if they get back out there, they get hit again, and they have that 50% chance of dying from that secondary impact syndrome. So, again, pretty scary how many concussions happen that are not reported. ER visits have increased over 200%, especially with the increase of sports out there. I mean, these little guys and girls are getting out there and playing younger and younger and younger. So, pretty scary. I think I might just keep my future children wrapped up in bubble wrap and in a rubber room after learning all of this. But all right, so every excuse me, every third day a student athlete dies from sudden cardiac arrest. This was a study done in 2012. So again, pretty significant number there going on all over the world. 85% of these deaths are due to cardiac emergencies. So again, that really stresses how important it is to have an AED out there and available right away. The most common cause of death is that hypertrophic cardiomyopathy or the enlarged heart. What I found awesome knowledge to have is minutes to defibrillation. So the earlier you can get defibrillation or shock done on a patient, the better their chance of survival. So every minute it decreases by 10%. So if you can get that AED on someone within 1 or 2 minutes, they have an 80% chance of surviving, as opposed to 9 minutes down the road, they only have about a 10% chance of surviving. So again, education and getting that AED out there and the awareness of how to use it is very important. This I found interesting, the commotio cordis. Baseballs is the big blue part there, the pie chart, 61%. That's the biggest cause for the sudden cardiac arrest. What I find funny is tennis balls filled with coins. I did not have a clue what that meant. Who would play with a tennis ball filled with coins? I was in North Dakota in April, and I mentioned that, and someone said that people use it for training for certain sports. They'll actually weight down a tennis ball and throw it and catch it. So there was my answer to that, but still very weird. But so as you can see, baseball, softball are the biggest components there to the commotio cordis. I thought this might be interesting for you guys. Between 2000 and 2007, you had 139 total deaths of ATV fatalities. For those of us females out there, we're pretty smart, right? Look at that. There's only, out of the 139, there was only 11 deaths of females because we know what we're doing. Females are the best drivers out there, aren't we? Men between ages 1 and 84, there was 128. So that big range there, 86 are 15 to 44-year-olds. So again, I like that female number. That's pretty cool to me. All right. Anybody have this kind of a crazy patient? He got tased a couple times. Yikes. So we are almost done. Hang in there with me for a couple more minutes. All right, so as a conclusion, again, the main theme for concussions, never underestimate a possible concussion, all right? Have a high suspect of injury for all these patients. Educate, educate, educate. Sudden cardiac arrest, again, remain calm. Another main theme is educate. I am a huge believer in educating the community and the public. You know, that's half of our job is injury prevention, right, as EMS providers. So I know there's enough crazy people out there that pretty much gives us job security out there because there's always going to be someone doing something stupid. But the more we can get out there and educate the population and the public, the safer and better off we all are. And the big and the ugly for fractures, you know, be prepared to treat for shock and definitely be prepared to do a surgical airway if you need to, especially for those Le-Fort 3 fractures that can be pretty nasty and scary. So again, I'd like to thank you guys for allowing me to do this for you. I'm still awake amazingly, so my coffee at 5 o'clock did very well. I hope you guys enjoyed it and learned a little bit of something. And again, thank you. This is my first time doing a webinar, so now I can say I did that, and you guys got to be my guinea pigs. So thank you, and I hope you had a really interesting time and learned something that you can take back. And go home and put that egg in a jar and see what you come up with.
Perfect. Thank you, Andrea. And is there any questions from anybody before we let Andrea go this evening? I'll give a couple of minutes for questions. Otherwise, if you guys don't have any questions, if you can send some feedback as to tonight's webinar. And for those of you that's been doing this regularly, this will be our last one for the summer, as us Alaskans enjoying our summers. So we'll be back on hopefully in August, maybe September, the latest. And if you guys have any topics that you would like to hear or find, so we can find speakers accordingly or put it out there for whatever topics you guys are interested in. I don't see any questions. I see a lot of thank yous to you, Andrea. So again, yeah, thank you, Andrea, for joining us this evening and doing this webinar for us. And hopefully we will see you again in November.
Yeah, thank you. I appreciate it. And I'd love to come see Alaska.
Sounds good. All right, everybody, thank you very much for joining us. And we'll see you